Welcome back from morning tea. So this next session, the way it's going, no, before I say that, I meant to remind you that you can get the full program on the conference app. So that's not the QR code. You have to go onto the conference app, and at the bottom of your name tag, there's the password to get to the conference app, so you can get the full program on the app. Now, the process for this next session, so we're looking specifically at the report that we launched just before morning tea, and what does that mean for science? So we have a panel of experts in different scientific fields with us today. What's going to happen is we have two presentations of approximately 10 minutes each, who will present. They've had an advanced reading of the report, and we'll look at what does the report mean for their respective fields, and then we'll have a panel discussion that I will chair. I've prepared a few Dorothy Dixer sort of questions to kick things along, but you'll get a chance to ask questions of the panellists as we go along. So I'd like to introduce our first presentation for this session is Miss Anna Maria Arabia, who's the Chief Executive of the Australian Academy of Science. Please, Anna.
Good morning, everyone. It's such a pleasure to be here. I too would like to acknowledge the Wurundjeri people, the traditional owners of the land on which we meet. The Australian Academy of Science has a long-held interest in advancing actions to improve indoor air quality. We consider the absence of enforceable performance standards a significant gap in Australia's public health framework, requiring priority attention. What gets measured gets managed. And in Australia, we don't measure nor monitor indoor air to scientifically understood standards and sensitivities. And so we don't manage poor indoor air adequately. Just a few weeks ago, 300 global leaders united at UN headquarters on the sidelines of the General Assembly to declare that we consider indoor air quality a basic human right. So far, more than 165 organisations have signed a global pledge recognising clean indoor air as essential to health and well-being, and that number is growing daily. I invite you to do the same if you haven't already. Maslow's hierarchy of needs includes air, together with food, water, shelter and sleep, as essential to survival. And so it seems inconceivable that in 2025, in Australia, and in most places around the world, action is limited in improving the air that we breathe in the places we spend around 90% of our time indoors. This, notwithstanding a robust and growing body of evidence, scientific evidence showing that poor indoor air quality has a negative impact on our health and well-being, and notwithstanding the known and available technological solutions required to address it. At the Australian Academy of Science, every day we seek to bring evidence to decision-making. We bring science to the service of the nation. And to do this, we lean on the extraordinary research effort across the nation and across the globe, gathering evidence and translating it for use by decision makers like ministers, policy makers, judges, teachers and members of the public. We especially lean on our fellows, Australia's distinguished scientists elected to the Academy for their sustained contributions to science. World leading in the area of indoor air quality is, of course, Professor Lydia Marowska. And that's why I'm especially delighted to speak here today at the launch of this 2025 State of Indoor Air Quality in Australia report on the potential impact of this report on science. May I first offer my congratulations both to Professors Wendy Miller and Professor Lydia Marowska on this extraordinary undertaking. The report is both pioneering and essential, provides the seminal baseline on which the research community must now build. Evidence it examines is as important as the gaps it reveals. For the first time, Australia has a national examination of indoor air quality through the lens of different occupancy modes, pollutant risks, exposure limits, health and economic consequences, and policy responses. By looking at indoor air quality across different building types, the findings assist in creating a hierarchy of need, illuminating where action should have the greatest priority and impact. Most usefully, it provides state breakdowns, empowering jurisdictional decision makers to act locally. And importantly, it debunks myths about what regulations, ratings, standards and laws do and don't exist, and how clean indoor air and energy efficiency standards can work hand in hand. History will show that this inaugural State of Indoor Air report is a line in the sand moment to birth further strategic research efforts to fill the identified data gaps and to allow the existing data to inform policy actions nationally and globally. I tried to skim through the report, but actually I couldn't. Each chapter revealed more and more, and it drew me in further and further. I think we've all been there. We need to prepare for something. We look at the report. Perhaps I'll just read the executive summary and I'll be right. Not this one. So I do commend it to you. And in fact, I ended up highlighting sections on virtually every page. And I still find it quite unbelievable that it's the first report of its kind and it's taken till 2025. It offers such fundamental information that I feel we should have had this decades ago. Such is the priority we need to give our understanding and response to indoor air quality. Whilst it's the first, knowing Lydia and the team at Thrive, I know it won't be the last. It can't be the last, because for the Academy to do its job of informing decisions with evidence, we need this report to drive action. I anticipate that the report will have impacts in 3 key areas. First is to fill data gaps. Deliberate action is needed to improve indoor air quality measurement and data collection in all building types. I was deeply struck by the paucity of published research on indoor air quality in many settings, including in healthcare facilities, where one would expect differently. Unbelievably, the report reveals that in Australia, the most bushfire-prone nation in the world, there is not a single published paper relating to private bushfire shelters. I was equally struck that the National Action Plan for the Health of Children and Young People and the National Asthma Strategy does not include indoor air quality in buildings. If gas appliances and wood fire heaters and stoves are especially detrimental to those with asthma, shouldn't priority be given to mandate indoor air quality sensors, at least in those homes, as a priority? Going forward, research investigations are required where scientists will need to work with stakeholders across various occupancy types so that we measure, publish and manage indoor air quality in those settings in a customised way. The second is prioritisation of action requiring decision makers in both the public and the private sector and across portfolios and jurisdictions to work together. Where data has been published, Wendy and Lydia have very eloquently joined dots across portfolios, and it reveals that there is much low-hanging fruit. How is it that in 2025 we need to wonder if medical professionals routinely ask patients with respiratory illness questions about gas appliances in their homes? Simple modifications of design principles could better separate the proximity of garages from living areas. The report findings illuminate whether specific classes of buildings are more suitable than others as potential evacuation centres in bushfires and other emergency responses. And it's clear that incorporating the design and operation of schools into the National Preventative Health Strategy going out to 2030 would have enormous impact. I found myself wondering why we didn't already have the answers to these questions. Each requires different disciplines and portfolios to work together. So I expect the report will assist in exerting pressure on political and policy leaders at the state and federal level, whether that be legislators, regulators and others in the chain of influence. And in the private sector, the findings provide invaluable insights to facility managers, owners and builders to support market and commercial decisions. We will be most effective when we work together in ways that we may not be accustomed to. The third is to inform global research and action. I understand the Global Commission on Healthy Indoor Air aims to develop a global framework for action. This cannot be achieved without national reports like this Australian blueprint. And of course, to make it truly Australian, the report even sheds light on a microbrewery that utilises an Internet of Things sensor capability to monitor carbon dioxide. I'll conclude by sharing that the Academy is currently finalising a report on indoor air quality, and it will provide a complementary resource for policymakers and is due to be published in November. As well as providing a primer on the scientific evidence base, our report explores policy pathways to routine measurement and monitoring of indoor air in public buildings to an agreed set of standards and sensitivities. The places where we work, live, learn and play must be safe and healthy. They have unique needs, challenges and pollutant profiles as illustrated in the 2025 State of the Indoor Air Report. Nevertheless, we must not let the complexity of the policy challenge distract from the clarity of the scientific evidence. The responsibility and the opportunity sits with all of us to work together across government, industry and academia to translate this knowledge into policy and practice. Congratulations again, Lydia and Wendy. I very much look forward to continuing our shared effort to improve indoor air quality for all. Thank you.
Thank you, Anna Marie. If you have any questions for Anna Marie, I just ask that you hold them for when we go into the full panel. Our next short presentation is from Professor Brendan Crabb, who's the CEO, I think that's the correct title, for Burnet Institute, which is a medical research association as a complementary thing to the Australian Academy of Science. So thank you, Brendan.
Thanks so much, and thank you to Kazance. If it was 1994, I most definitely would not have been at that meeting. I don't come as an expert in clean air or clean indoor air, and slightly embarrassed to be up here speaking to you all, but mostly just honoured, and it's been fantastic to have met many of you in the clean air space, and especially the clean indoor air space, and have been championing it for 30 years and longer, and just to now be a part of that step change, as Lydia said, as a result of the pandemic, to progress something you all know is important and is known as has been important for a very long time. What I do have some link to clean air. I work on malaria, and that's my technical area of expertise as a scientist. Malaria actually means clean air, bad air. It means bad air. And of course, for a long time, malaria was thought to be transmitted by miasma, the smell from swamps. In the same way, typhoid was thought to be transmitted. And of course, it was Ronald Ross, about 130 years ago or so, who discovered malaria is actually transmitted by insect. Still called bad air. Air has nothing to do with it, of course. Swamps do, but only as breeding grounds for mosquitoes. And of course, those sort of lessons, public health lessons, and I'm going to mention one or two others in a moment, have happened from time to time. But the key reason I'm here, though, is because I'm interested in ways to accelerate the change into practice, into a healthier community. And it turns out that with all of the changes that we talk about, and I mentioned mosquito transmission of malaria, obviously understanding that bacterial gut infections and viral gut infections transmit by water, another big one. They get actually scientific acceptance often quite quickly. This is not trying to win over overcoming a paradigm. We've had to, in the clean air space, overcome a paradigm. The next step of translating into people can take a long time. As we'll mention it now, given I'm here, but the slow discovery of typhoid transmission and cholera transmission won him fame. It was very well accepted, but it did take 60 years before even the world's leading cities really instigated the sorts of change that needed to happen. 60 years, even then, after the broad acceptance. So I'm interested in accelerating things. And just in a nutshell, the state of play, I think, from where we were pre-pandemic, pre-bushfires, at least in the Australian context, in the world pre-pandemic, to where we are now, is there's no doubt there's been a step change. And it's a profound step change. But we're probably only about halfway to the impact, to really translating that to healthier communities, our own community and communities throughout the world, no matter what the income status that they live in. And so how do we accelerate that without needing another catastrophe? We respond pretty well, the world does, to catastrophes. We don't want another one to have to go that extra step. Now, we might debate this in question time. Is it just going to happen now? I don't think it will happen without a really significant push. And the gaps are technical. There is lack of understanding of exactly what to do where. And the gaps are psychological. Right? So one of the sort of key moments in the pandemic was a little town in the northwestern corner of the US called Skagit. And Skagit had choir practice one evening or afternoon, and the HVAC system, as I understand it, was turned off for choir practice. Anyway, large COVID outbreak amongst those choir, number of those died, and it became sort of a signature piece for, you know what, this is an airborne transmitted disease. The other thing, though, that keen observers noticed was it's really a signature moment for the way it transmitted beyond it being just by the air. Firstly, that it was an indoor air disease. The vast majority of COVID infections, the vast majority of all respiratory infections transmit inside. And the second is that COVID has a very high dispersion factor. That means very few people do most of the transmission. Of course, there's been a focus on the people. Turns out it's not the people. A lot of people can transmit. We know this from home-based studies. In the home, there's quite a lot of transmission. No matter if someone's positive, there's a fair chance they're going to transmit those very close to them. It's the building. It's the nature of that indoor environment. So this is pretty good news, really, because what it says is if you know the type of the circumstance that is going to promote infection. Lydia once said to me about the Victorian classroom project where HEPA filters at the height of the emergency were placed into every classroom, which is great. But she said something to the effect, I'm paraphrasing you, Lydia, is what if we only needed those in 5% of the classrooms? And therefore we could just put them in those 5% or 10% and use the rest of the money to make sure they were installed properly, make sure that air quality was monitored, make sure it was working well. So the challenges are really significant to go that next step. We are halfway. We were probably 1% of the way prior to pandemic. All of a sudden, we're 50% of the way. But there's a long way to go yet. So I'm going to race through just a few slides that effectively say what I've said already. Air quality, the air we breathe kills about 20%, is responsible for about 20% of the deaths in the world each year. So it's a killer. Of course, air quality means a lot more than death. These figures you could argue with bits here and there, but it's a very substantial killer. Interestingly enough, in our institute, we work a lot on tuberculosis. Airborne transmission has never been controversial for tuberculosis. It's not controversial for measles either. it's kind of weird how selective we are about respiratory infections that all transmit in the same way. COVID is still a killer. We don't know exactly the numbers. We look at excess death figures as best as we have them. So this is the baseline situation at the moment. Influenza, and of course, as this group, Skazance knows, outdoor air pollution generally is a major killer. So there's about 60 million deaths a year in the world, 12 million from air. And of course, it's the baseline. What's got us here, to probably having this conference 30 years later, what's got us to this point of talking to prime ministers and so on about clean indoor air is the pandemic, where, you can have a really sudden driver of fatality and morbidity. Very high chance, of course, of more pandemics and more airborne pandemics. The frequency of events. I hadn't realised, Lydia, that a catalyst for some of those that work with SARS-1. Of course, since SARS-1, we've had 2 other coronaviruses. So we have 3 coronaviruses in the best part of 20 years that have made it establish themselves in humans, SARS, MERS, and SARS-CoV-2. And of course, there are plenty of other respiratory infections. In Australia, we're particularly concerned about Hendra virus and its Malaysian counterpart, Nipah virus, totally new respiratory transmitted infections. As humans encroach more on the environment where native species, particularly bat species, live, then the frequency of transmission of new infections is there. We've also got old infections still with us. The top of the list, SARS-CoV-2, of course, influenza, where in my world, we've been most worried about an influenza pandemic for much of the last 30 or 40 years. There is a very high likelihood of us having to face more airborne pandemics. Pretty low likelihood, by the way, of facing waterborne pandemics, but only because we have the infrastructure in place. And that's the key message. You get the infrastructure in place for clean indoor air, you're not very likely to have these in just the same way as waterborne. Of course, you can have major epidemics of waterborne disease where in countries and regions where there isn't that infrastructure. We're not worried about the water we're drinking out there, right? I mentioned this already. We can't afford to delay it. There's amazing things that have happened. I mentioned mosquitoes, hand washing, non-snow, of course, in sanitation, but it takes a long time to get the change. So it's absolutely fantastic to have this blueprint that has been introduced so well by Wendy and Lydia already. Please, you've got it on your chair. It is a historic moment. And one of the things it says is that inherently, it doesn't mean every building is unsafe, but there's no class that is exempt from concern. And in this sort of review of 106 or so papers, there were a lot of different building types, from schools and homes and offices and hospitals and aged care facilities and so on. Over 2,500 studied across for the different pollutants that were measured. What was found is that there wasn't any single business building type that was exempt. Residential, I think has been mentioned already, but it's not just pathogens. It can be gas appliances and wood heaters, for example, major problem. I think the cooking with gas story might have been mentioned earlier, but responsible for up to 12% of childhood asthma burden in Australia. I think Wendy might have mentioned that. Schools, lot to be learned and so on, but a quarter of all classrooms having CO2 readings nearing 2,000 for 3 or more hours, where our kids spend most of their waking life in a classroom. So this really matters. And of course, share it with quite a few others. 10% of classrooms had CO2 readings above 2,500 for 3+ hours. And that's just, we know there's a lot of more that needs to be done in assessing classrooms, but this is the published data. The highest recorded in a classroom was 5,000. Of course, CO2 is a marker of poor air quality from pathogen perspective. It's also bad. CO2 itself to be in for long periods of time, and from a cognition and performance, brain performance point of view. In offices, and it's great to see our friends from Neighbours here, but the IEQ ratings primarily cover only premium buildings. Everything in offices is so heavily influenced by HVAC design. In healthcare and residential care, there's high CO2 has been observed and published in staff rooms. Of course, this is just what we do know, not what we don't yet know, and that the particle concentrations have varied so much between different zones in hospitals. Come from the outdoor airspace and not the infectious disease space, you may not be so aware about the really dangerous place many healthcare settings are for people to get respiratory infections. By far, the number one cause of hospital-acquired infection is respiratory transmission of COVID at the moment, which is often fatal. So you don't go in there for COVID, but you get COVID in a hospital. So obviously hospitals and the healthcare systems are very keen on mitigating this. But what do they do in the most cost-efficient way? How do they know where to make a difference? I'm not saying this out of blame, just saying this out of, this is a hotspot that needs to be addressed. So it's a blind spot in public health. 3 out of every 10,000 buildings has any IAQ measurement, according to this report. And of the impressive 106 papers that are published, over three quarters of them come from just 2 states, Queensland and Western Australia. So there's a lot of data that isn't there for southern states, Victoria, New South Wales, Tasmania. By the way, the rate of death from COVID increases as you go down the east coast. Tasmania is the highest, Queensland's the lowest. Likelihood being time spent indoors and the nature of those indoor environments. And in residential aged care, obviously a very high risk setting. We've got schools, we've got healthcare facilities, we've got residential aged care. Only 3 studies of the 106 were in residential aged care, and almost none in regional Australia. So it's a blind spot. So the point of the report is that it's not an endpoint, but it's a call to action. And I love that baseline line. That kind of implies that we must see the next version, and we must accelerate and build on the incredible data that is here. This is not going to be a textbook. It's a call to action. So we're going to educate and empower people. We have to monitor indoor air quality across the community and work toward setting standards. That's the holy grail, of course. And it is what makes people's eyes glazed over, because they think, yeah, we want that too, but that's not going to help me now. So we do have to deploy existing solutions now. We have to get going. There's not don't let the perfect be the enemy of the good in this. And of course, we need to invest in innovation in catalytic ways to address the technical barriers to what to do and the psychological barriers to transitioning to taking this as seriously as we do the water that we breathe. So one approach that has been introduced already by Lydia is the Clean Air Consortium, with the colleagues here from different institutions led by Suman Majumdar at the Burnet. Fantastic to have and be a part of this. As I say, the whole clean air thing's been a learning experience for me. But the way this team has got together and got a plan and approached the Victorian government, we had a treasurer, interestingly enough, not a health official, not a health experienced person, a person who could see that this was key to progress in the state. He cared about economic development, I've got to say, mostly. Tim Pallas had broad support, but Tim Pallas was a major driver of this. And I think there's lessons in that for how we advocate. The Pathway to Clean Indoor Air, there's kind of two projects, the Pathway to Clean Indoor Air project and the Elucidar project. Broad-based Pathway to Clean Indoor Air is implementation research in 212 rooms across Victoria in schools, public sector workplaces and community spaces. It's about developing and testing and refining scalable indoor air quality solutions with implementation started just this September, so last month. And what it does is addresses that where there are gaps, translation gaps between evidence and real world practical use, to understand the key barriers and enablers for the real world. Like, you know, if it's only 10% of classrooms, which 10%, which classrooms, and what can be done in those classrooms, that might work. Elucidar's a bit different. It's an RCT, randomised controlled trial, which of course critics in this space often, in our health space, often asked for. And that's also something maybe we could discuss. Anyway, it is a randomised controlled trial of germicidal UV within residential aged care, 60 residential aged care facilities across Victoria. Obviously testing this for room UV. It's an incredibly ambitious project, and these sorts of projects are a bit scary because while you're pretty confident, you know, UV is going to decontaminate the air, real world setting is another matter, and can you have it statistically power it enough to see an effect when, you know, residents have a life outside of the rooms that will be in. Anyway, it commenced in early 2024 with an outcome available in early 2026, so pretty soon. So that's kind of we're at a really exciting place. I'm a glass half full person, so I like to stress that things have advanced so much on the back of those of you who built this clean indoor air and of course air quality in general, evidence base and advocacy space over such a long period of time. We've then had this explosion of interest. We're now halfway. We need to, as a group, address in a really smart way those practical barriers, evidence-based barriers to practical implementation of tool, and the very real psychological barriers to making change when it's not an emergency. That is not easy. And we're seeing this across the public health spectrum of you know, driven so much by misinformation and disinformation, for example, apathy in general, for understandable reasons, for also reasons driven by bad actors and so on. It can be very hard to instigate significant change, especially when the perception is there's upfront cost involved. So that's the challenge for us all. With this, we have a major step forward. Thank you, everyone. Thanks very much.